Hello, and welcome to my presentation on perinatal care in Kenya, health disparities in antenatal and delivery care. The United Nations, in their Universal Declaration of Human Rights, Article number 25, states that everyone has the right to a standard of living adequate for the health and well-being of himself and of his family. They go on to say that motherhood and childhood are entitled to special care and assistance, and that all children, whether born in or out of wedlock, shall enjoy the same social protection. Ghebreyesus, in 2017, when he was leading the WHO, said, "The right to health for all people means that everyone should have access to health services they need, when and where they need them, without suffering financial hardship. No one should get sick and die just because they are poor or because they cannot access health services they need." In their article by the Human Reproduction Program, the WHO wrote on childbirth that every woman has the right to the highest attainable standard of health, which includes the right to dignified, respectful health care throughout pregnancy and childbirth. They go on to say that abuse, neglect, or disrespect during childbirth can amount to a violation of a woman's fundamental human rights. In Kenya, under the 2015 National Guidelines to Quality Obstetric and Perinatal Care, focused antenatal care includes 4 antenatal visits that are comprehensive and personalized. It should include early detection and treatment of problems. Care providers should be looking to prevent complications using safe, simple, and cost-effective interventions. Care providers should be teaching clients about birth preparedness and complication readiness. There should be promotion of health using messages and counseling and nutrition counseling. There should be provision of care by a skilled attendant, and the 4 visits should include individual birth plans, checking physical parameters, dispensing preventative medications, counseling, educating, and counseling on breastfeeding. In the same 2015 guideline from Kenya, delivery care is described as having 3 main components. There should be a skilled attendant, which may be a doctor, a midwife, a nurse, or clinical officer, and they should have the skills to manage normal deliveries and diagnose or refer for complications. The environment should be enabling and should include allowing the person to be in whatever position they want to be to push, and to allowing other partners to be there to support the person giving birth. This includes the traditional birth attendant. And care should have a high standard for universal precautions for all and good hygiene. They should minimize vaginal exams, use a partograph, avoid unnecessary trauma and interventions. Breastfeeding should be held within 1 hour of birth, and skin-to-skin contact should be encouraged. Unfortunately, Kenyans who live in the lower socioeconomic status do not access quality antenatal and delivery care. Harris defines health disparities as differences in the incidence, prevalence, or burden of disease in a subgroup when compared to another population. Sharma et al. Looked at 3 domains to measure the quality of care in Kenya. They looked at facility infrastructure, they looked at the clinical process quality of antenatal care, and the process of delivery care. They state that quality of care increases with decreasing poverty across those 3 domains. They also stated that it was significantly poorer quality for women and living in poor areas. The facility infrastructure made a major difference in whether a person received quality care or not. In wealthy counties, there was a cesarean section available. People could choose between private and public facilities. The maternal mortality was according to the national average, which is 495 per 100,000. 69% had adequate access to maternal care, and 24% had access to quality delivery care. However, in impoverished counties, of which 5 counties make up the most impoverished counties in Kenya, there were difficulties with transportation. There were only public facilities available. The maternal mortality was on the low side, 790 per 100,000, and on the high side, over 3,000. 56% only had access to any sort of adequate maternal care infrastructure, and 8% had access to quality delivery care. In Kenya, only 9% of people receive effective antenatal coverage, and this means that only 17% of the country gets minimal quality delivery care. 5 dimensions of quality antenatal care include effectiveness in service provision, efficiency and readiness, accessibility of services and equipment, acceptability and satisfaction of patients, and safe provision of service by a qualified provider. Guidelines for quality care include blood pressure measurement, hemoglobin tests, urine tests, and palpation of the client's abdomen for fundal height. In clinics that did not provide quality care, the care provider did not follow these guidelines. Quality clinics had electricity, piped water, and were well equipped with medications. Those clinics that were not high quality were inconsistent with their electricity, they didn't have piped water, and many were not equipped with the minimal medications needed to provide safe care. In wealthy counties in Kenya, quality care was available to 24% of the population, but in the poorest counties, only 8% had access, and only 62% of births in Kenya have a skilled birth attendant. This plays a strong impression on the rural communities. When someone living in a rural area has to decide whether or not to go to the facility, one of the key decision makers is the family. The husband, the mother, or the mother-in-law will decide whether or not that person can go to the clinic. Their geographic area can make a major difference. If they have transport or do not have transport, if they live near the city or not, they might be afraid of having their baby along the way. The health facility and the impression that the facility has left on them can make a big difference. They might be aware that the facility doesn't have medications or gloves or essential items. However, if the health facility has drugs available and they know that they might be given a gift after the delivery of their baby, they might be more willing to attend that. The experiences of these clients make a major difference in whether or not they will go to the facility. Some view the facility as unnecessary or they've received bad advice. Some are worried about the gender of the birth attendant, or they're afraid of having to deliver lying down. Perhaps they've experienced disrespect, abuse, pinching, shouting, or there's no service at night or personnel are refusing to assist them. Depending on whether the person at the clinic is willing to accept the traditional birth attendant or gives quality care will make a major difference as to whether a client will go to the clinic to have their baby. Moving forward, how can we improve access? Peterson et al. State that ensuring access to quality care, including specialist providers during preconception, pregnancy, and the postpartum period is crucial for all women to identify and manage medical conditions. Zhang et al. State that early initiation of prenatal care allows for assessment and earlier treatment of maternal disease, which positively affects pregnancy outcomes. And Sharma et al. State that researchers estimate that competent intrapartum care could avert 1/3 of maternal diseases and over half of neonatal deaths annually. There is an essential need to improve all disparities to see substantial change. According to Uwili et al., there are studies that have shown that expanding coverage does not necessarily mean quality healthcare services. The quality of care itself must be improved. And the existing level of care cannot improve the population health. So even if universal coverage comes into play, these populations will continue to suffer. There are 5 ways that we can work together to improve care and outcomes for those people who are in the lowest socioeconomic classes of Kenya. First of all, we can work on improving the social determinants of health, such as education and financial preparation. Those people who were educated were 7 times more likely to seek to have care in a clinic, and those people who were financially prepared were more than 3 times likely to seek the same. The healthcare services themselves can be improved. For one, by providing culturally sensitive care. The gender of the provider matters to most of these people giving birth. They're twice as likely to go to the clinic if the provider is female, as well as accepting the traditional birth attendant or those who accompany the client. Providing quality antenatal care will encourage people to see the benefit and the willingness of the clinic to work with them, and will give people a desire to come into the clinic so they will have their baby there. Finally, quality delivery care is absolutely necessary. If people are mistreated, if there's a lack of privacy or lack of informed consent or unhygienic practices, those people who might have considered going will decide not to go. Leah Kibete famously stated that there's a saying in Africa, to find out you're pregnant is to have 1 foot in the grave. With Kenya's maternal mortality being well over 400 per 100,000 women dying, and the Sustainable Development Goal being less than 70, it is imperative that action be taken to provide quality antenatal and delivery care for all Kenyans regardless of their socioeconomic status. Here are some references. There are 2 pages of it. You can also view these on your lecture notes.